Okay. So, as we said, untangling the truths and myths of non-suicidal self-injury. Okay, one of the first things that usually happens is that oftentimes self-harm is thought to be linked directly with suicide, right? But that's not the case. So, unfortunately, the two tend to get grouped together because they're inflictions of pain. And sometimes people who begin with self-harm may later actually go on to commit suicide. Generally, though, people who self-harm do not wish to kill themselves. It's really more of a mindset of dealing with pain versus feeling that there are no options. So that's really the one significant difference is the intent. On the flip side, people who self-harm view hurting themselves as a way of coping with life. So in fact, for some, the infliction of pain reassures them that they're still alive. So there have been plenty of times, at least in my life, where I've gone through some emotional stuff and I've been so wrought with emotion that you get to a point like when you feel numb. And that happens sometimes with people who are self-harming, is that they get to that place of numbness, and sometimes they inflict pain in order to like, oh wait, yep, I can still feel things. I still have the ability to do so. Self-harm can also cause changes in your brain chemistry, which gives the side effects of a rush and can easily become addictive and dangerous. So that's part of it as well. Very early on in my career, and I've had permission to share this story by my client, but very early on in my career, I had worked with my first self-harming client. And she was in her 20s at the time that we met, and she had began self-harming fairly early on in her life. And because she had injured herself with knives, with razors, that wasn't doing anything for her anymore. So she had progressed to burning herself. So because we were working on reducing her symptoms to get her to a place that she can eventually stop self-harming altogether, we did have an agreement that if it was an injury that she couldn't take care of herself, that she would go to the emergency room or go to the doctor to get properly taken care of. I was home one night. It was about 10 o'clock at night. I had gotten a phone call from a number I didn't recognize. I answered it. It was one of the ERs in one of our neighboring counties. And it was the emergency room doctor. And the emergency room doctor was trying to Baker act her. He didn't know what to do with her because she was self-harming. He took it as there was no differentiation in his mind between, okay, well, she's trying to kill herself. And I had to explain to him in a lengthy conversation on what her diagnosis was, where she was at in treatment, and that she in fact was not suicidal. So that had led me to move on to study non-suicidal self-injury more in depth because of that misunderstanding that I was seeing with medical professionals, with psychiatrists, and other people within the community. But a little bit about self-harm in history. Self-injury has existed for nearly all time, right? I mean, if you go back to the beginning, self-injury has become more pervasive in the United States, and it's been growing, and the more social media that we have, so on and so forth, the more that we're becoming aware of it. But for historic purposes, it has been used in religious or spiritual practices, including purification, transcendence, or penance, right? During the 5th century BC, leaders would slice their flesh prior to battle. There have been shamans who have dismembered themselves in an attempt to attain religious reconstruction and purification. During the Christian era, Priests and zealots wounded themselves in attempt to model themselves after Jesus to attain salvation, as Jesus himself did by dying on the cross. In some primitive societies, body modification, infliction of pain, tooth extraction, and the slicing or removing of body parts were rites of passages. Self-injury has provided punishment and degradation for individuals who feel unworthy of love, relationships, and life in general. Self-injury has been utilized to reassure survivors of abuse that they're still human and not just objects. Contradictory to the aforementioned, self-injury is also to assure individuals that they're tough, resilient, and able to take abuse and carry on with life. Now, if you go back into modern day, which 1990s is no longer modern day, but in books, films, television, and other forms of media, that's really where today's culture has derived self-harm from. So especially when celebrities come out and discuss it, Drew Barrymore has discussed it, Johnny Depp, Colin Farrell, Angelina Jolie, Princess Diana and Amy Winehouse before they passed, Demi Lovato. They've all publicly acknowledged their personal struggles with self-injury, which really brought the issue to the forefront, and giving self-injury a human form that people could identify with. And again, with the growing population of the internet, social media, Reddit, Facebook, whatever, you name it, websites focusing on self-injury began to appear. Websites came complete with chat rooms that ranged from real positive, which was peer support to recovery, to the negative, which is actually peer support for engaging in and continuing self-harming behaviors. Now, one of the tough things that we've come across in the clinical field when you're working on the therapist side is that self-injury, there is no uniform definition or terminology. So you can ask 15 different therapists or 15 different doctors, you get 15 different answers. Terms that are all often interchangeably used with self-injury, self-harm, deliberate self-harm, self-mutilation, self-destructive behavior, self-cutting, self-wounding, delicate cutting, and parasuicide. And often these terms are used interchangeably. When we're looking at different cultures, such as different tribal and religious practices, such as self-flagellation, which isn't as common anymore, circumcision, and similar rites of passage, those actually blur the boundaries between institutionalized cultural practice and a medicalized problem, causing further difficulties in the development of a uniform definition. So we do have, those cultural and religious pieces as well when we're on the therapist side, when we're working with a client or people who are experiencing or disclose self-injury, knowing what the context is and where that all is coming from. So due to the lack of consistency in the literature and the research in terms of definition and vocabulary used to discuss self-harm, it's actually difficult to determine the prevalence of it, right? So again, when we take a survey, it's going to be based on the interpretation of the person that's filling out the survey. So statistical data on this is going to vary. Also, because of the secretive nature of it, the behaviors may be difficult to identify, which is actually another challenge to determine the exact prevalence of it. Back when the first research studies were being conducted in this field, a 2002 study reported that 14% of high school students had self-injured at least once. A 2001 study reported 35% of undergraduate students stated a history of self-injury. A 2004 report showed that for every 100,000 adolescents, an estimated 750 to 1,800 engaged in self-injurious behaviors, which translates to roughly 150,000 to 360,000 students nationwide, with the higher percentage of it, 70% of it, being women or girls. Various studies conducted in 1989 and between 1989 and 2003 reported that between 62% and 69% of the individuals who engaged in self-harm had a history of child abuse, with about 36 and 50% of those reporting sexual abuse. Of participants in previous studies, 78% stated that their self-injury had been conducted as a compulsive action. So not necessarily pre-planned. Of the participants, 15% reported that their decision to self-injure was made 1 hour prior to engaging in the behavior itself. And additionally, 81% reported that once they made the decision to self-injure, they actually followed through with it. So a series of studies indicated that approximately 70% of individuals who self-injure viewed it as an addiction because they felt that once it reached a certain point, they didn't have any control over their actions. When we talk about the different forms of self-harm, the most common forms are major self-injury, stereotypical self-injury, and moderate superficial self-injury. And these forms are classified based on to get, more medical based, but it's based on degree of tissue deconstruction, as well as being, an episode, repetitive, or a compulsive behavior. So when we're looking at major self-injury, that includes more severe and often potential life-threatening injuries. These are more rare, but they do happen. So we're talking about self-castration, removing an eye, and limb amputation. Major self-injurious behaviors are isolated in occurrence and generally appear when an individual is suffering from severe psychosis, intoxication, or a severe character disorder. So something that's really, above and beyond, and things that are really hard to get under control, sometimes even with medication. Individuals in this category engage in major self-injury resulting from a profound disorder or of perception or thought. So individuals do not necessarily recognize the irrationality of their behavior. They're engaging in it, but they're not cognizant of the fact that I'm doing something and I really shouldn't be, but I'm doing it anyway. They just don't have that. Even further, individuals who engage in this form of self-injury have often reported no pain and experience of calm before, during, and after the injuries occur. When we go to the next level, for lack of better terms, this stereotypical self-injury includes head banging, self-hitting, face slapping, lip and hand chewing, self-biting, hair pulling. And this is most typically seen in individuals with organic mental health disorders. They don't always accompany a mental health disorder, and I'll talk a little bit more about that later, but they don't always have to be paired with the mental health disorder. The pattern in which these behaviors occur is fixed and highly repetitive, causing a range of mild to severe tissue damage. Episodic self-injury occurs only a limited time throughout an individual's life. Repetitive self-injury is associated more with reoccurring self-injurious behaviors with more of an addictive quality, and is incorporated into the individual's life and personality. almost like a routine. The most common form of self-injury appears to be skin cutting. That was utilized by more than 70% of those who self-injure. Banging, hitting, and burning are common forms of self-injury. However, scratching appears to be like the most common as far as other forms are concerned. The area of the body most likely to be injured is the arms, followed by the hands, wrists, thighs, and stomach. In my experience as a clinician, I've seen mostly like the torso and the upper thighs. But again, it just depends on there's many different factors which drives a individual's reason to harm a certain area over others. Depending on the type of harm in question, the action of self-injury may be deliberate in its undertaking. So actions such as punching a wall in anger, seen typically in males, that may be considered an impulse rather than deliberate. I spoke with an individual, a male, and he had stated that he had engaged in self-harm as a teenager and would there'd be like punching of objects, those kinds of things, and people thought he was doing it out of anger, but it was causing damage to his hands, to his wrists, and that was his form of self-harm that he was able to hide because he was a male, and he's just unfortunately typical male getting angry and overreacting. When we look at the onset, self-injury typically occurs in individuals between the ages of 13 and 23, which of course, as we all know, is a period of developmental significance. The onset could be triggered by a specific stressful situation, or basically by the tumultuous nature of early adolescence, and how, as adolescents, we were all there, how we define what's tumultuous is, varies from individual to individual. Adolescents who self-harm, there's a possibility that they may have not learned to cope with strong emotions, and then they may have, as a result, they may have a negative self-image and a poor sense of resiliency, things that were just never, they may not have been taught that. Most self-injurious adolescents experience chronic anxiety and rage, and the rage is typically against themselves, not against other people. They're dissociated from reality, emotional numbness, and they have a sense of depersonalization and powerlessness. Self-injury has been found to be 3 to 4 times more common in women than men. So self-injury typically is a gendered and developmental phenomenon for women because they're subjected to intense social cultural pressures throughout their lives. If you're not familiar with the book Reviving Ophelia by Mary Pfeiffer, she wrote this fantastic book. It's called Reviving Ophelia, Saving the Cells of Adolescent Girls, I believe is what it's called. And it talks about how when teenage girls, they come into puberty and they're in that gray area of age of, preteen through teen, why there's like the emotional disconnect with the family and the reconnection and all of those things that take into consideration. And she actually updated the book a few years ago because she wrote the book like 25 years ago. She updated the book to include, social media, reality TV, and all the other crap that we're now all subjected to as humans, and how that affects girls as they're growing in their development, and how they process that. So that's a book that I usually recommend to other clinicians who work with teenagers. I also recommend it to parents, of preteen and teenage girls, to kind of help them navigate through and get a little bit different understanding on how to, on what they're experiencing at home. I have 5 daughters. I know that around age 10, 11, they turn into, personality-wise, they turn into aliens, and then about 22, they return, and you go, okay, there's my kid. But it's really because of these things that they're experiencing, out in the world and not knowing how to translate that. Going back, as we talk about women and girls, statistically, there's lower numbers. Men have not reported engagement in self-injurious behaviors. And when they do talk about hitting or burning themselves. Again, those are things that are easily explainable, and as well as easy to be overlooked by other people. When it comes to self-injury, individuals, they're having difficulty feeling at home in their own bodies, right? So by keeping feeling and emotions at arm's length, individuals become alienated from themselves, and they use self-injury as a maladaptive coping behavior that fulfills one or more need in their life. When you talk to individuals who self-harm, they've characterized their backgrounds with histories of abuse, abandonment, separation, and loss. Issues within the family system and social isolation has been prevalent in these reports as well. Often they'll describe their self-injurious behaviors as an attempt to kind of crawl out of their skin, right? To like as an escape of feelings of emptiness, worthlessness, ugliness, and shame. It's also been utilized in the scenario to self-soothe. Individuals who self-injure also have some hold underlying beliefs that they have a lack of self-control and are impulsive, resulting in the inability to cope with the unbearable effect in cognitions in a more adaptive and thought out way. So doing something that's more healthy as a coping mechanism, it takes too long. It takes too long to master. It takes too long to feel better. So the use of self-injury is maintained, and it's repetitive because it's a short-term, immediate method of coping. Self-injury may also emerge or increase in an effort to protect abusive caregivers. So they're injuring themselves to hide injuries that may be happening to them from somebody else. Or it's been used to use it as a way of taking control of being victimized. Because what happens is, engaging in self-harm, the individual decides when, how, and how much he or she will be injured. So that's taking control back in their lives. Sometimes self-injury is used to obtain recognition, attention, or other forms of connection, which, that can be identified as secondary gain. Self-injury is used to manage, and we touched upon this a little bit earlier, about managed depersonalization and more extreme levels of dissociation. Some individuals use self-injury to invoke dissociation, so they use self-harm so they check out, or it can be used to bring them back out of emotional numbness. But there are some individuals who engage in self-injury simply due to the minor stressors associated with everyday life, family problems. They can do it as a mode of rebellion, upsets with friends, romantic relationships. You know, I when I work with teens and I work with their parents, you know, a very real question is posed is how do we prevent it? They're afraid to give their children rules, enforce rules, have them do chores, yell at them if they do something wrong, so on and so forth. So they almost give them all of this permission because they're afraid that if they do something contrary, it's going to upset the child and the child is going to go ahead and self-harm. And, you know, the thing that I discovered, you know, in research, as well as, you know, as well as working with families, it doesn't matter. You can give your loved one the perfect day. Everything is their choice. You give them everything perfect under the sun. And depending on what their reason for self-harming is, if that reason is not gone, they will still find a way to engage in that behavior, no matter what it is that how we try to set the stage for perfection for them. In the early history of self-injury, individuals were often hesitant and unsure about like what they were really doing and how they felt about what they were doing to themselves. Some reported that they didn't really have a clear purpose as to why they were harming themselves. Some were like, my friends are doing it, I'm gonna try it, you know, kind of thing. And other people who had engaged in self-harm, they were disturbed by their behavior. So they wound up not doing it again. But when people tend to go back to engaging in self-injurious behaviors, the tendency is to escalate the frequency and the intensity. Some individuals became more active in their self-injurious behaviors, describing them as a craving and psychologically addictive. As individuals continue to harm themselves, it became more difficult for them to stop. They also began to evolve in their use of implementations, locations of injuries, and the type of harm they caused themselves. Sometimes due to curiosity, and other times due to lack of efficacy of their previously chosen method. Now, when you talk to individuals who self-harm, and this is not a blanket statement for everyone who self-harms, but self-injury is viewed as helpful rather than harmful, because the action releases an intolerable buildup of emotions, right? That emotional pain that came into existence takes up residence within the client's body. And for the client who engages in self-injury, the response is to cut the emotional pain out of them. One researcher called it cutting the bad out of me, right? So self-injury is sometimes seen as an attempt at self-help by providing that immediate short-term release from anxiety, depersonalization, racing thoughts, and emotions. By self-harming, sometimes by the release of blood, like watching the blood come out, the messages that the neurons in our brain receive when it happens, all of that leads to that craving and that psychologically addictive piece of self-harm. So much like any other addiction, to do more of it and to do more intensity to create the same benefit as when it initially started. And that's something that becomes a tricky piece for people who are working in mental health care and for loved ones who are trying to care for somebody who is engaging in self-harm, knowing how to how to help transition them from that. Self-injury can lead to the decrease of tension, euphoria. It can improve sexual feelings. It can diminish anger, satisfaction of self-punishment, security, uniqueness, manipulating other people, relief of feelings from depression, loneliness, loss, alienation. Again, it could provide a sense of control, confirms the presence of one's body, dulls feelings, and converts unbearable emotional pain into manageable physical pain. I can't tend to my emotional pain, but I can tend to a wound that I have created on my body. I can take care of that. I can see myself taking care of myself, and I can see that wound healing, which is a really significant piece when we're like working with people, or when, you know, we love somebody who self-harms. Self-injury in a real and literal sense is the client's history and pain. It's written right onto their body. You know, when I spoke about my client at the beginning, you know, of this workshop, the only way that I was able to, we had seen each other for a few years, and it was probably our second or third year together. She felt comfortable enough to take off her jacket in front of me. And the only way that I was able to accurately describe it is it looked like tiger stripes, and it went from her wrist all the way up to her shoulder on both arms and on the front and back. So, and again, she was in her mid-20s when she started seeing me. I think she said she started when she was 8 years old. So she has literally written her entire life of pain on her body, on her arms. So clients who self-injure write the text of their inner pain on their skin, and that, you know, and it transforms them, not just emotionally but physically along the way. So in that regard, self-injury could be seen as a desperate attempt to provide a picture on the outside of the client's experiences and effects of what they experience on the inside. Another thing that happens with self-injury, they try to pair it with a mental health diagnosis. It's typically borderline personality disorder is the one that's usually thrown out there. But to date, even in the most recent release of the DSM, self-injury has not been identified as an individual diagnosis of itself, but it has been identified as a byproduct or potential symptom of depression and borderlines. Just because somebody self-harms does not mean they have borderline personality disorder. That is one of the biggest things that I had gotten from people who self-harm. There are people that were coming to me diagnosed with borderline personality disorder that definitely were not borderlines, but because they had self-harm, medical professionals, other mental health professionals who are not trained in this particular area did not know how to categorize them. So it winds up being a classification thing and not really looking at it from an individual behavior and root cause perspective. Self-injurers report higher levels of depression, inadequacy, loneliness, anxiety, hostility, somatic complaints, anger, aggression, impulsivity, disinhibition, and a greater difficulty with body comfort and confidence, such as negative self-image. But these are all symptoms, not diagnoses. So again, when you have somebody that self-harms, as clinicians, it's not lumping them in with an immediate diagnosis that they've got to carry around with them. You know, it's about addressing the root of the behavior, reducing and removing it with healthier coping skills. Diagnoses that sometimes you will hear thrown around with people who self-harm include eating disorders, mood disorders, dissociative disorders, disruptive behavior disorders, anxiety, and OCD. The link between self-injury and these diagnoses is really not surprising because they have negative emotionality and emotional dysregulation as part of their primary features. Typically, eating disorders are prompted by negative emotions, which are similar to the negative emotions that precede an individual's engagement in self-injurious behaviors. Well, going back to the suicidality piece, although acts of self-injury have been linked to suicide, most self-injurious behaviors are not suicide attempts, but are actually used by individuals to avoid suicide. However, individuals who have self-injured may have considered suicide or tried to harm themselves more seriously. And if the individuals have not, an attempt may have been, may be made in the future. So, of course, with people who self-harm, conducting a safety assessment, just as you would if somebody who came to, as clinicians or medical professionals, somebody who comes to you who has the characteristics of somebody who is contemplating suicide. Yes, also considering that and looking at that with people who self-harm, because you do want to make sure you're doing your due diligence and not potentially missing anything based on what's reported to you directly by the client. Self-injury is a survival technique. It is a reaction to almost unendurable circumstances or internal experiences in the individual's world. It's intended to allow the individual to endure and carry on instead of being the expression of hopelessness and helplessness presented by suicide. Self-injury is not typically an expression of a wish or decision to take one's life, but it is important to be aware that unintentional death could occur due to overdose, infection, or other severe trauma that somebody has caused to themselves. Most individuals, they self-harm to preserve their lives. If you're a treatment professional or your loved one is working with a treatment professional, if the treatment professional believes the individual's engagement in self-injury is inevitable, then the relief the individual experiences is understandable in the terms of damage limitation and is used as a form of life preservation. Just like my client that I spoke about earlier, she wound up moving out of state, but we were many sessions away from her getting to a place where she wanted to stop the behavior. We were looking at harm reduction versus removal of the behavior altogether. If you are a clinician or if you are a loved one and you are trying to find a clinician for somebody in your life who is self-harming, that has expressed a desire to stop, treatment professionals who handle self-injury, they need awareness, relevant knowledge, understanding, and skill. Appropriate treatment of self-injury requires training and support. This right here is definitely not a training, it's an information session, but there are plenty of training programs out there. There are fantastic training programs out there. that people are more than welcome to reach out to me, and I can connect you with, if you want to be able to learn more in more of a educational setting about this topic. Treatment professionals are better able to help when they understand the psychological meanings and purposes of the individual's self-injury. So start by exploring their meaning and their purpose, right? Getting that background. Even if your loved one is not working with a treatment professional and you're just trying to understand, trying to avoid the, oh my God, why are you doing this to yourself? I know that on the loved one side of it, it can be very, it's very distressing, and you don't know what to do, and you feel real ill-equipped to know how to help somebody. But providing a space where they can try to explain it and make meaning of it for you can help you both work together to try to figure out like what's the next best action to take and solution for their care. Now there's a lack of specific treatment protocols for self-injurious behaviors. A lot of times dialectical behavior therapy will be called upon, which is a fantastic technique. Cognitive behavioral therapy has kind of received the most research attention as an evidence-based treatment for reducing self-injury. So usually the use of functional self-assessments to kind of inform like where the individual stands in their thought process, teaching specific skills, using behavioral interventions, and implementing cognitive restructuring. So a lot of times it's changing our thought pattern. But these are all things that take time, and they take practice. When individuals who have self-harm have been asked about what has been the most helpful for them when getting care, these characteristics have been identified as being helpful. Listening, clearly, but active listening, understanding, and acting as a friend. So really not approaching it from our sterile clinical lens, but really just allowing space for the person to be vulnerable and to be themselves. Individuals desire a treatment professional who is able to actively listen and communicate understanding rather than judgment. So again, I know the majority of clinicians out there do not do this, but reacting with, oh my God, why are you doing this to yourself? Or wording in that similarity, not helpful. It will not allow someone to open up. And they also desire a personal connection with their treatment professional, like in terms of a partnership. They want to feel like it's a partnership rather than somebody dictating over them. But it is important for treatment professionals to be direct, honest, respectful, and behave working with the client in a trustworthy way, but without necessarily expecting the client to trust us. We kind of have to prove that over time. And again, that builds the partnership. The behaviors that are unhelpful is forcing ideas upon the individual during the therapeutic process. If the treating professional is devoid of empathy, it could have negative psychological and emotional effects upon the individual. treatment professionals should be comfortable with letting the individual cry, talk, rant, without criticism. And then just help them to start employing alternate coping mechanisms. And the most important thing is the individual may still engage in self-injurious behaviors during the course of the therapeutic relationship. You know, that is their main coping skill. That is sometimes their only coping skill. It is going to take time and patience, and you know, the participation of the treating professional and the individual to get to a place where they can start substituting that out with healthier coping skills. So comprehending how this individual's self-injury is carried out, how it's felt and interpreted, with the range of emotions from the individual's experience. So just as much as their underlying pain and the feeling and the root causes are pertinent to their story, the preparation, the practice, and the aftermath of the self-injury is important as well. It's not just the feelings, but it's also the physicality of it, that as treatment professionals, medical and mental health, that is important for us to understand. So examining the emotions, psychology, motivations beneath the wounds benefit both the client, both the individual and the treating professional. Self-injury is a maladaptive coping behavior, and it fulfills a multitude of needs in the individual's life. So a goal should be obviously to help them develop alternative coping and communication skills, to help build the individual's self-esteem, create a sense of connectedness, and really asking, you know, what does these self-injurious behaviors mean to the individual? You know, why do they believe that they engage in this behavior? Why do they choose? Why is it something that they continue? And again, you know, it's not from a standpoint of judgment, but it's from understanding. And I always like to preface that to the people I work with. I will tell them, I will ask why a lot as we're getting to know each other and as we're working through things. And it's not because I don't believe you or I'm questioning you or I'm judging you. It's, I want to understand what your meaning is. And hoping by asking the why questions, it helps you to dig deeper and really get to the root of it for yourself so that you can understand why. So that becomes, you know, it's mutually beneficial, but it also creates that partnership because we're working together to, you know, to dispel whatever myths, whatever narratives the individual has come up with as to why they need this in their lives and what they can do instead of it. It's important that, you know, remaining current on the topic. So much has changed over the years. Again, the accessibility, you know, people in the field, you know, all of that has changed so much over the years. So by having a, you know, staying up on research and these different things is really important to have. And really, you know, clinicians, medical professionals, peers, you know, be in conversation with each other. So again, like I said at the beginning, like I am not the be all end all on this topic. So, you know, creating a space where we're learning from each other is really, you know, where the understanding comes from. And just like any other mental health issue or challenge that's presented, that's the way that we're going to learn. And that's the way that we're going to help each other and create a space where people who need help or want help can get that without the stigma.
forgot to unmute myself. But thank you, Danielle, so much. That was so interesting. And I feel like I learned some new stuff that I didn't even realize was self-harming behavior. So it was really interesting. But yeah, so we're gonna open up some Q&A for you guys. You guys are more than welcome to unmute yourselves, turn on your camera, or just even ask questions in the chat, whatever anyone is most comfortable with. And we can start with that. So if anyone has any questions, the floor is open.
And if there's anything that anybody wants to share, anything that they've learned, anything that wasn't included in here, please feel free to put that out there as well.
Mm-hmm. Anyone?
That's okay. I'm gonna put my email address. Oh, okay, hold on.
There.
What does one do if a minor commits self-harm and the authorities want to Baker Act them? Well, I think it depends on there's and they aren't suicidal. Well, I think it depends on how the authorities has been notified. Was it the school? Was it a treating professional? Because a lot of times if you're a therapist working with a client, you're not gonna call authorities to Baker Act a client, right? Because you know better, because you know your client and you know what you're engaging in. But when it comes to schools, there are other kids who see self-harm and they don't understand it themselves, so they report it to a teacher. That becomes an issue. If they're under a clinician's care, they should definitely be reaching out to the clinician. A lot of times they don't. So what happens is the child is Baker acted unnecessarily if there's no intervention. And that becomes problematic. Donna, okay, thank you. You're welcome, Linda. Yeah, I think many clinicians do not have a grasp on self-injury and more should hear presentations like this. I agree. When I did when I went for my doctorate, this is actually what I did my doctorate dissertation on. And my research study was based on interviewing other therapists. So a lot of my content actually came from my dissertation, because I studied the topic for 5 years and I talked to a multitude of clinicians, just again, just to get their definition and what they've done with clients and how do you diagnose them and all of those things. So there really is a big disparity in the information that's out there and what's available. And it's just, something that's not taught as frequently. So yes, I do telehealth and I am taking new clients. So I will put my email address in the chat. So, but if anybody has questions or something that they come up with later that you didn't think of right now, please feel free to email me, of course. If you guys want referrals to other educational programs, continuing education, self-harming programs, there was actually one inpatient self-harming program. I can't remember what state it's in. I don't know if they still exist, but they were doing a self-study continuing education for clinicians. But there's groups and everything else, that happen as well. So if anybody is in need of that, please feel free to reach out. I do have a ridiculous amount of information on it. So please feel free to reach out.
Where will this recording be available? So once it is uploaded, so we have to upload it to our cloud. That's where the recording gets sent to. And then once it's fully uploaded, I'm going to send it to everyone who registered for this Zoom, because some people registered and didn't attend, just so that they are able to see the video. And then also it'll be on our YouTube and on our website, our NAMI Greater Orlando website too. So thank you. Yeah, but it'll take like maybe a week or so to fully upload. It takes a really long time for some reason. But once it is fully uploaded and I can make it into a file, I'll email it out to everyone. Also, welcome. We Anyone have any more questions or comments for Danielle in particular? Um, thing at all?
That's okay. You know, it is Monday, so.
Yeah, it is Monday, right before Halloween too.
Exactly, exactly. So, well, I thank everybody who joined us today, and being able to be here with everyone.
Yes, thank you guys all so much, and I'll make sure that the video goes to all of you for sure.
Oh, Nora, yes. You know, that there was a book that came out years and years ago when like self-harm, first became, I hate to say popular, but and it was something called, like, it was like a workbook. It was called like See My Pain or something like that. And they were like techniques like diversion, techniques, but really what was happening is that they were replacing like one behavior with another. So like some people were talking about, like, writing on your skin, or like taking a rubber band and like flicking a rubber band. You're still perpetuating the act of self-harm, even though you're not actually harming yourself. So diversion um, isn't necessarily helpful, other than like going old school and employing like the same things that you do when you have a client, when you're working with you know, a no suicide contract, when you're doing that, calling a friend, going for a walk, so on and so forth. So what we don't want to do is we don't want to replace it with any type of like a physical behavior that can kind of be run along the same lines of self-harm. But thank you for that question. You're welcome.